Hello and welcome to your OB course. Today we're going to be reviewing some interventions or intrauterine resuscitation. Okay, so interventions for non-reassuring fetal heart rate patterns are referred to as intrauterine resuscitation. So these are interventions that we perform for the benefit of the baby while still in utero. Okay, these interventions aim to maximize intravascular volume, uterine perfusion, placental exchange, and oxygen delivery to the baby. I do have a picture here of the threats to fetal oxygenation, okay, that cause fetal hypoxia, which is the equivalent of fetal distress, okay? So when we have a mom who has hypotension, the intrauterine or the perfusion to the placenta perfusion is compromised and ultimately impacts the baby. If we have uterine contractions, okay, the vessels constrict and it affects the blood flow that's going to the baby. If we have a nuchal cord, for obvious reasons, this also impacts the oxygenation that the baby gets. Maternal and placental vascular disease, such as preeclampsia, vasoprevia rupture. We'll talk about that in other chapters, but it is a condition that you must be aware of. Uterine rupture, placental abruption complete, cord prolapse, maternal seizure as a result of eclampsia, and IVC obstruction of the uterus. So these are all events or things that can occur that will compromise fetal oxygenation. All right, and then so we're going to talk about how do we address this. If these things are going on, what are we going to do? So I have a little red, yellow, green traffic light over here. If you have a category 3, which we know means that you have absent variability with recurrent lates or variables and or bradycardia or a sinusoidal pattern, in this case, this is serious. You have to stop. You have to intervene. If your client is on oxytocin or pitocin, you must discontinue it, and you have to expedite the delivery of the baby, whether it's through an operative vaginal delivery or a cesarean section. What is an operative vaginal delivery? It means that the physician has to get this baby delivered and that they may use forceps or a vacuum. With a category 2, what are our interventions? Okay, we might want to consider discontinuing or decreasing the oxytocin infusion. We want to consider the potential need to deliver if the abnormalities on the strip persist or worsen. All right, this is when we watch. We watch what's going on with our baby, but we also intervene. Do we have to just maybe bolus mom, give her more fluids, reposition her, stop the oxytocin, things of that nature? And when you have a category 1, it's in green, which means just continue. Keep on doing what you're doing. You just keep on monitoring and you cross your fingers so that it remains as a category 1. And here I have a picture of what uterine hyperstimulation looks like. What is uterine hyperstimulation? Another vocabulary word that's important to know in order to understand fetal monitoring and the interventions that you must do. Okay, it means that you have 5 or more contractions in a 10-minute period. Okay, in this particular picture, we have 5 contractions in 7 minutes. Think about this. Every time a client has a contraction, it decreases the placental perfusion to the fetus. So think about somebody making you hold your breath, okay, for a minute. If you had to hold your breath or decrease the amount of breaths that you take, for 5 minutes out of 7 minutes, I think you will be in distress. A lot of people, I'm sure, will pass out. Well, the same thing happens to the baby. When a person of client is contracting too often, all right, 5 or more times in a 10-minute period, they can deplete their placental reserves of oxygen and eventually become compromised and develop hypoxia. So when we have uterine hyperstimulation, we must address it. How are we going to address it? Well, number 1, is my client on oxytocin? Am I, in one way, shape, or another, causing these, excess of contractions? And if my client is on oxytocin, I might want to decrease the number of units that I am administering. If I am at 20 units, I might want to drop it to 10. And if it's severe, then I might just want to discontinue it altogether, all right? And it also depends, the aggressiveness with which I will handle this would depend on what my fetal strip looks like. In this case, we can see that the baby had a variable, but the rest of the strip looks really good. They have moderate variability. So this baby is not in distress. However, if I allow this client to continue in this fashion, the baby is no longer going to look this good, okay? Chances are variability is going to start decreasing and go from maybe the moderate that it is to minimal, maybe even absent. I may start seeing recurrent, or I may start experiencing late decelerations, remember? So I want to address it before that happens. I don't ever want it to get to that. Anytime we administer oxytocin, yes, we want to augment the labor process, but never at the expense of the fetus's well-being. Okay, so we want to address it. We don't want this. This is not a labor pattern. We administer oxytocin to achieve a labor pattern. A labor pattern is a contraction every 2 to 3 minutes that lasts 45 to 60 seconds. On this image, we see that this patient is contracting basically every minute and a half, or every minute. In some cases, not even a whole minute. All right, so we want to make sure that this is something that we address. Intrauterine resuscitation. When a non-reassuring fetal heart rate pattern is identified, assessment may include, all right, depends on what you have going on in your pattern, all right? If I start seeing early decelerations, I may want to go and do a cervical exam and assess, maybe my baby's crowning. That's on a good day, right? If I have recurrent variables or a prolonged deceleration, right, of the baby's heart rate, I might want to go do a VE or vaginal examination to check, and maybe I have a cord prolapse, which, by the way, it's an obstetrical emergency. We're going to get into details of that in another chapter, but you need to know that when the umbilical cord comes before the presenting part, that baby can no longer be delivered vaginally, and they must do a cesarean section stat urgently. It's an obstetrical emergency. If again, all of a sudden my patient was maybe 3 centimeters and all of a sudden I see early decelerations on my monitor, I want to go do a VE, because it could be that she went from 3 centimeters dilation to 10 centimeters dilation and delivery is imminent, so I have to assess. Rapid descent of fetal head. Sometimes babies will have prolonged decelerations. If, let's say, mom decides that it would be a good idea to push without her nurse being there, and she does a great job at pushing, and that baby goes from being at a -3 station to a 0 or a +1. You also want to assess uterine activity. If you have uterine tachysystole, like we just saw in the previous slide, right, you want to assess, am I utilizing oxytocin or any other uterotonic? Okay, what am I doing? Is there something that I can do? Maybe my patient is dehydrated. One thing you will find is that patients who are dehydrated tend to contract. Most women come to the hospital with contractions because they are dehydrated. You get a urine sample and their urine looks like iced tea or Coca-Cola. All right, they are severely dehydrated. Women must drink a lot of water when they're pregnant. So that's something that we have to assess. Maybe you just have to bolus your patient and the tachysystole will go away. You also want to assess maternal signs. Anytime that you see any distress, any fetal distress, assess maternal signs. If your baby was fine and all of a sudden you start seeing tachycardia, maybe mom has a fever, all right? Maybe she's dehydrated. Both of those things can cause tachycardia in the fetus. Maternal hypotension. Let's say your client just got an epidural. One of the side effects of an epidural is hypotension. Let's say she was not properly hydrated before the procedure, during, or after, and her blood pressure drops. Guess what's going to happen? Placental perfusion also decreases, and ultimately it affects the fetus. So what are you going to see? You're probably going to see fetal bradycardia. The baby's heart rate will drop. What are you going to do? Your intervention is going to depend on what is causing the distress to the fetus. In the case of hypotension, you want to increase maternal blood pressure. How are we going to do that? Yes, you can give ephedrine. The anesthesiologist can give ephedrine. or you can simply bolus them, give them more fluids to increase maternal blood pressure. Maternal position change, okay? We know, we learned last week, and we've seen in previous presentations that I've provided, that we have what we call supine hypotension. When mom lays flat on her back and it suppresses or depresses, compresses the inferior vena cava, we can cause distress to the baby. So what are we going to do? We want to reposition mom. Maybe the baby doesn't like mom being on the right side, and when she's on the right side, she compresses the umbilical cord. So you want to shift her to the left side. So repositioning is important. You can do repositioning or change maternal position to minimize or correct cord compression, decrease the frequency of uterine contractions. Generally, if your patient is tachysystolic and you put her on her side, the frequency of contractions will decrease. And because you're now no longer compressing the inferior vena cava, you will in turn improve uterine blood flow. You may also want to administer IV bolus fluids to maximize intravascular volume and to improve uteroplacental perfusion. This is a great intervention in the example that I just gave of maternal hypotension. Then administering O2, that's another intervention that we can do as L&D nurses, okay? How do we give O2 to our pregnant patients? Unlike in a regular med-surg floor, we generally give 8 to 10 liters per minute via a non-rebreather face mask, not a regular nasal cannula. If I tell you, if one of your choices for an answer is 8 liters via nasal cannula, it's wrong. We always give through non-rebreather face mask. You have to have a face mask, okay? Again, we have another example here of what uterine hyperstimulation looks like. And then you have another example of late decelerations at the bottom, all right? So as you can see, the baby's heart rate drops at the peak of the contraction. So we have, what do we have? Depleted oxygen reserves. So do we want to administer O2 to mom? Yes, because indirectly it'll go to the baby. Again, 8 to 10 liters via non-rebreather mask. Then amnio infusion. We're going to talk about what an amnio infusion is, right? You know that we talked about IUPC, an intrauterine pressure catheter, that we can utilize once your client is ruptured, given that they don't have any infections. Once they're, roughly 2 centimeters dilated, we utilize this IUPC to measure the intensity of contractions. But guess what? That same tool can be utilized to infuse the uterine cavity with fluid, warm fluids, okay, normal saline or LR that we put in there. Why do we do this? When we have a client who has oligohydramnios, meaning very low AFI or amniotic fluid index, this can result in recurrent variable decelerations, right? We don't want this. If we have this and we know our client has oligohydramnios, the provider can perform an amnio infusion. It's a therapeutic option, like I said, when you have recurrent variable decelerations due to the decrease of amniotic fluid. Please note that the normal saline or LR must be room temperature, and it is infused into the uterus cervically via an IUPC. Okay, it increases the amniotic fluid to cushion the umbilical cord and ultimately reduce the number of variables or cord compression. You usually bolus 200 to 500 mLs, and it's given over a 20 to 30 minute period. And then sometimes they'll remain continuously giving her an infusion of about 120 to 180 mLs per hour. Okay, and it may be done for a maximum of 1,000 mLs. After that, no more. Please note, contraindications for an amnio infusion are vaginal bleeding, uterine anomalies, and active infection. We never want to do anything invasive if the mom has some type of infection. Another reason why we would do an amnio infusion a lot of times is when a baby passes meconium in utero. In order to prevent meconium aspiration when the baby is born, meconium is feces, the baby's poop, okay? when the baby is born, in order to prevent aspiration of meconium, they kind of flush out the fluid so that it decreases the amount of meconium in utero. And here you see, the equipment that has to be used. You have to be continuously monitoring the baby. And then where the catheter goes, okay, in the amniotic fluid space. And then these were the variables that you would be seeing a strip. Another form of intrauterine resuscitation. Remember, this can occur at any moment. In this case, we see a woman, she's already pushing her baby. All right, so this is the second stage of labor. Let's say that during this period, the baby becomes flat, meaning absent variability. And this baby's in distress, maybe starts having late decelerations. How do we handle this if mom is already pushing? You have to allow a little more time for the baby to recover. So instead of having your patient push with every single contraction, you have her push with every other or every third uterine contraction. Again, the idea is to provide or give the fetus more time to recover. And this occurs during the second stage when mom is already pushing the baby. Important during this period of time, if you are providing intrauterine resuscitation, it's very possible that your client and your fetus is in distress. This can increase anxiety, makes mom and the family, whoever's there, very, very nervous. Your job as a nurse is to provide support to your client and their family. In order to help decrease anxiety, you want to make sure that you're managing the pain properly, that in the process, you are improving uterine blood flow. How do we do this? We reposition mom. Remember that you maximize oxygenation. If your patient needs oxygen, you put her on oxygen. You put her on her left or her right side, lateral. If you have an ominous fetal heart rate pattern, a category 3, okay, please note this is associated with fetal acidemia. And in this case, when we have this category 3, we want to make sure that we are calling a physician. Please note in this case, the presence of a physician for evaluation must occur as soon as possible. The idea is that they have to come in and that they can make the call, that they can say, you know what, I need to perform a cesarean section. This baby needs to be born now. And you already have the provider there, right? But again, psychosocial support is also important. Yes, you want to make sure that you take care of the baby and that you do every intervention possible in order to improve the fetal status, but at the same time, you have to keep control. You have to make sure that you let the family and the client know that everything's okay, that she's in the right place, and that you are doing everything that can possibly be done in order to help the baby and your client. And we have a little picture here, fetal monitoring, and it's an acronym for you guys to remember what everything means. Veal, top to bottom vertically, veal, chop. And if you put them next to each other, variable, you can remember that it's associated with cord compression. E is for early decelerations, and it's indicative of head compression, which is an expected finding if the woman is progressing through labor. A, from the word veal, stands for accels, accelerations, and they are A-OK, all right? Meaning if your client has accelerations, there's nothing for you to do. You cross your fingers and hope that they continue to have them, because this is what we want. Accelerations are indicative of good fetal reserves and oxygenation. The L in veal, late deceleration. These are not good. We don't want this, particularly if they're recurrent, all right? It's indicative of placental insufficiency. If your client is experiencing, if you're looking at a strip and they have late decelerations, you need to make sure that you are doing interventions. And then here we have more patterns, which I know you've seen before. This is what an acceleration looks like. These are basically late decelerations, and these are recurrent. You have one after every single contraction, okay, which is very, scary. A variable can look like a V or a W. And the key with variables is that from the baseline, the drop to the nadir or the bottom of the variable is quick, less than 30 seconds, okay? Variable decelerations are variable in duration, intensity, and timing. So, they can be deep, they can be, shallow, but it'll be like a quick drop. And it happens within less than 30 seconds. Please note, it's important that you understand that to promote fetal oxygenation, one of the biggest things that we do is that we place mom in a lateral position, whether it's left or right. We may want to provide IV fluids, all right, particularly in the case of hypotension. If they're on oxytocin and your fetus is in distress, you want to discontinue that. If they're pushing, if they're in the second stage of labor, you want to alter the pushes. So push with every other or with every third contraction. Administer O2 at 10 liters via non-rebreather face mask, not a nasal cannula. Remember that. So we want to make sure that we address the uterine activity. We want to make sure that we alleviate cord compression. Again, repositioning is a great way of alleviating cord compression. And then maybe amnio infusion. Remember, with reference to the cord, if we have an umbilical cord prolapse, we have to elevate the presenting part. Why do we elevate the presenting part? The presenting part is generally the fetal head. We want to elevate it so that it does not compress the cord. And you have to make arrangements for an expedited delivery, generally a C-section. And then again, with maternal hypotension, we also want to put in a lateral position to increase placental perfusion. And you want to bolus your patient. And if they don't respond to those two interventions, then you usually call the anesthesiologist or your CRNA, and they will consider administering ephedrine, 5 to 10 milligrams IV push. So I hope that this, again, spiked your curiosity and that you go back and read some more on all the intrauterine resuscitative measures that you can do in order to help your patient and their baby. Until next time.